Kia ora everyone and welcome to this MedTalk. My name is Dr. Grace Lee and today I'm talking to Dr. John Perry, a gastroenterologist. We'll be going through a case of reflux, so let's get started. John, I've got a 42-year-old gentleman who has some breakthrough symptoms of volume reflux and heartburn despite being on 20 milligrams of omeprazole BD. What further history should I be checking for?
Well, classically, we want to look for alarm symptoms first just to make sure they aren't having dysphagia, odynophagia, which is pain, usually a sharp pain on swallowing, and weight loss. And odynophagia and weight loss are kind of like a classic lower esophageal cancer combination. Other things, I guess, patients who are Māori or Pacific Island have an increased risk of GI cancer, and or family history of GI cancer is important. It might change the path you take to heading straight for a gastroscopy. After that, you want to think about lifestyle factors, particularly weight gain, smoking, caffeine and alcohol. They're sort of the standard four you think about. Some patients you'll need to clarify between whether they have reflux and whether they have dyspepsia. It may take you down a different pathway. Your patient, though, has classic reflux symptoms.
There are no red flags, but his weight has been gradually increasing, 8 kgs over 5 years. No smoking, no alcohol, but he does like his caffeine, 2 cups of coffee or more a day. What should I be advising this gentleman?
Well, weight gain is a common cause of worsening reflux, and there's an old study showing that if you can lose 5 kg in weight, you can halve the amount of reflux going on. So that is a goal to achieve for this sort of patient. Caffeine is relative low-hanging fruit because you can switch to decaf relatively easily, and decaf usually tastes okay these days, whether it's tea or coffee. If a patient's smoking, that's another long-term goal for every GP. Stopping smoking won't necessarily prevent reflux, but it will mitigate some of the other risks associated with it. Alcohol also works too, like caffeine, to relax the lower esophageal sphincter, so it's something else we can try and decrease, though often it's harder for some patients. There are some other options to consider, like propping the bed up or having meals earlier, and that'll depend on how well it works for the patient, and it might help some patients.
Are there any suggestions for medical management?
So with these patients, reflux isn't classically associated with Helicobacter pylori, but it is something that should be tested for before starting omeprazole, really because it has some long-term associated risks, particularly in Māori, Pacific Island, Asian patients with gastric cancer. If you can test with a stool antigen test before you start omeprazole, it's a worthwhile thing. It's harder later. The serology tests aren't as sensitive or aren't as accurate. Once you've taken that out, then you've got to consider medications. Once you're talking about treating reflux with medication, typically we use proton pump inhibitors. Patients who are on these already can have the dose increased. They can have twice daily PPIs. And you can consider switching from omeprazole to pantoprazole or lansoprazole or back and forth depending on what they've had already. There are individual differences between patients. There are some studies suggesting omeprazole is stronger than pantoprazole, but I think that probably varies depending on generics and individual patients. If you can't get control by optimising the doses and optimising the timing, so half an hour before breakfast or half an hour before dinner, then you can consider adding domperidone in before meals. Domperidone is a prokinetic, and the idea is to try and empty the stomach and decrease the reflux that's coming up. Important point to that drug, though, that is you need to check the QTC or QT interval just to make sure they haven't got a prolonged QT and be at risk of complications from that. Nocturnal ranitidine is something else that can be considered. It does work well for nighttime breakthrough reflux. It doesn't work forever, though. Usually it loses its effect after a year or two, so it's more like a bridge to address lifestyle factors.
When would you consider a gastroscopy?
Usually we consider a gastroscopy in patients that have symptoms that are refractory to medical management and lifestyle modification. Also patients with new onset of symptoms over the age of 45. Some DHBs it's 50 or 45 for patients who are Asian or Māori and Pacific Island because they are at increased risk. Obviously patients with red flags such as odynophagia, weight loss, dysphagia should be referred.
The H. pylori test is negative and his symptoms have begun to resolve on 40 milligrams BD of omeprazole. He's also initiated some of those lifestyle changes. What do we need to consider now?
Well, PPIs are considered safe when they're used correctly, but they do get overprescribed and some patients stay on them for a long time unnecessarily. If someone gets symptomatic control on higher dose PPI, then usually we wait a few weeks and then try and titrate it down. Patients who are having 40 milligrams twice a day of omeprazole can go down to 40 milligrams just once a day. And then from there, if they address some of the lifestyle factors and can get the dose down, you'd go to 20 milligrams once a day and then see if you could just go to a PRN basis after that. You have to avoid dropping the dose too quickly because hypergastronemia will cause a rebound surge of acid. And you warn patients about that, so they may get a bit of heartburn for a couple of days after cutting down the dose. Ultimately, if patients can be on an as-required dose of the PPI, they'll do better. If they can modify their lifestyle factors, they may achieve that. Some patients can just have Gaviscon, Mylanta, some other simple antacid, and that can help with breakthrough symptoms. And so long as there isn't severe esophagitis present, this is perfectly reasonable.
Finally, what are some take-home messages?
Well, I think firstly, consider red flags and refer patients appropriately for endoscopy if they have them. You need to address lifestyle factors. They're really important. If you do that, you can get many patients off PPIs or just get to a as required or PRN basis. With patients with resistant symptoms, though, I'd consider adding in domperidone or possibly nocturnal ranitidine and then withdraw them when they're no longer needed. When prescribing PPIs, you want to optimise the timing, so half an hour before main meals. You can increase the doses, but then consider having a top-down initial strategy and then titrating down over time. If you can get patients off them, then that would be the ideal goal.
Thanks, John, for coming in today.
Thank you.